Saurabh. At the outset, I must thank the organizers. Am I being heard? Am I being heard?
Yes, sir. Very, very clearly, sir.
Okay. At the outset, I would like to thank the organizers of this refresher course for giving me the honor to chair this session, especially Dr. Rajneesh Bajwa and Dr. Ravi Kumar, who are very good and dear friends of mine. Next, we have with us to speak on this topic a very dear friend again who is in Pune, Dr. Simab Sheikh. And I thank him very much for accepting our invitation to be a part of this refresher program. He did not take a moment of thought to say yes to my invitation. Thank you very much, Dr. Simab. Now to tell you about Dr. Simab, he is an ENT surgeon with a clinical experience of over 25 years. He is the head of department at Inamdar Multi-Specialty Hospital, Pune, and a consultant ENT surgeon and sleep. Dr. A.K. Agrawal, please mute yourself. Thank you. Thank you very much. He is the head of department at Inamdar Multi-Specialty Hospital in Pune and a consultant ENT surgeon and sleep specialist at KEMA Hospital and Sahyadri Group of Hospitals in Pune. He is an international acclaimed speaker and a very famous name in the field of snoring and sleep apnea. He has done pioneering work on sleep apnea in India and abroad. He is also the founder, national president of the Indian Association of Surgeons of Sleep Apnea. Along with it, he is a part of the team which gives us for creating guidelines of sleep apnea amongst ENT fraternity. He has been extensively trained in this subject from Germany, Norway, Singapore, and many other countries. He is a very keen academician and a well-known teacher. Dr. Sheikh simplifies the complicated issues in this field to make comprehension of the subject easy for everyone. I'm sure everyone here will enjoy his presentation and take home very good take-home messages. Dr. Simab Sheikh, please take over and enlighten us about this very complex subject.
Thank you, sir. Thank you, Dr. Subhash, sir. It's always been a pleasure to be with senior people like you, sir. And it's been a long time. COVID की वजह से हम मिल नहीं पा रहे हैं. But there was no question of me to even have thought even for half a second, sir, आपको हाँ कहते हुए, because the respect for the academics also that is there and the kind of work that you all are all doing. So at the outset, I must really thank Dr. Garg, sir, for having me here and for the entire team of IMA, the chapter at Kanpur. And I know that organizing an event is sometimes not so easy and there are a lot of people behind the scenes. So a big thank you to all of them that are concerned. And without much further ado, I'm going to try and I'll share my screen and start off so that later on, if there is things, we can take some question answers. So do let me know if you can see this screen clearly. Somebody can just let me know if the screen is clear.
Yes, sir. Yes, sir.
Okay, great. So I've been asked to try and speak with the target audience being primary physicians. So my talk is going to be trying to make a lot of messages and understanding of the subject for a lot of people. And I'm sure there will be quite a few consultants also who would like to be, made aware of the myths and break the myths that are there with regards to snoring. So in the next few minutes, I'm going to try, although it's going to be a very Herculean task because many a times all we knew about snoring was something that you see, a light at the end of the tunnel, and we are only aware about, a few things about it. And in the next 15 to 20 minutes, I'll try to condense that kind of work and give you some idea of the fact that sleep is not a luxury. What we normally think, a Sunday afternoon siesta after lunch is definitely luxurious, but it's not just a luxury on a day-to-day basis, it's a necessity. And if you see that we are always advised to have roughly about 7 to 8 hours of sleep in a day, that's about 1/3 of the 24 hours. So we also understand and take into account that we have to invest. And I put the word invest in apostrophe commas because we do a lot of other investments, but we don't invest in our sleep. So for peak performance, like Dr. Gupta also mentioned about the mobile not being able to function the next day, you must be having at least 1/3 sleep of your entire day so that you can work well the next day. Let me give you a brief understanding of the airway. So when the airway starts from the nose all the way down, this is I'm sure you can see my cursor, and this is the awake standing up position. But when you lie down, all the soft tissue, whether it's the soft palate, uvula, the tongue base, epiglottis, there is a good likelihood of all of this falling behind because of gravity and thereby blocking this entire airway. Now, what happens when the airway gets blocked is obviously there are hypoxic events. So you're not getting the required oxygen saturation that you otherwise would. And imagine yourself drowning. So what is the response to the body when you drown? The response is an adrenergic response, right? So you try and do everything possible and the body starts pumping in a lot of adrenaline into your system. And you can imagine, because we talk about adrenergic response, or we had a very, adrenaline rush creating surgery and things like that. But imagine having adrenaline pumped into your system with every breath for night after night, for months after months, for week after weeks. So what is going to happen to your system? You have to understand that everything that is now there is related to this kind of adrenergic response and the tissue hypoxia that happens. So snoring is but obvious because of the entire fluttering of that soft tissue. The night sweats, palpitations now get very well understood because why is it happening? The choking episodes of night, obviously because your airway is getting totally blocked, and people describe this in many manners as ghabarahat and things like that. And you will hear of them, telling you that we woke out of sleep with a sudden fright, and there is disturbed sleep because of that. And as a consequence, then there is a daytime sleepiness that happens because you have not slept well through the night at all. So if you understand the basic pathophysiology of what is happening in sleep apnea, then you will be able to understand very clearly how each and every symptom has a pathophysiology related to it. Similarly, the same reason of disturbed sleeps will give you the early morning headaches, and then the neurocognitive symptoms start coming in, where you have irritability, short temper, inability to concentrate. Then you have interpersonal related issues that lead to a lot of marital issues. And in our country, decreased libido is something which is not taken very well. So all of these eventually become a neurocognitive symptoms of the entire disorder that we are now facing, and the pathophysiology is related to this. Those were the neurocognitive, and the same thing translate to cardiac muscle injury, or to, for that matter, you'll end up having hypertension, you'll end up having cardiovascular issues with systemic hypertension, cor pulmonale. All these eventually are because of an underlying associated sleep apnea, where pulmonary hypertension becomes one of the major causes, or rather one of the major sequelae of untreated or improperly diagnosed OSA. So we know now that the neurocognitive symptoms will relate to a lot of this: fatigues, headaches, behavioral problems, which till now we were not really attributing to this entire disease. But if you continue to see patients of chronic sleep deprivation, these are the most common things that they will tell you with regards to not being fresh in the morning. That becomes a very pathognomonic or a very classical sign of sleep apnea. Generalized lethargy, not wanting to do anything. And all in all, this will eventually result in a very poor quality of life quotient. whether it's at work, whether it's at home, whether it's your day-to-day ability to progress in life. And eventually that is what we try to qualify it with, a pure quality of life quotient. Now this, fortunately now over the past 10 to 15 years of me being in it, and we're trying to increase so much awareness, this kind of realization has come to our medical fraternity. So the cardiologists now dealing with the ischemic heart disease do understand the importance of underlying sleep apnea. The other most important thing that should always hit your mind is if you have a patient of uncontrolled hypertension or uncontrolled diabetes for that matter. So I have a lot of physician colleagues now who send these patients back to me for underlying OSA, because you may be treating them with the best medication, the most appropriate dosages, the most clinically sound physician looking into them, but yet the hypertension or the diabetes is not coming under control. Then the first thing that should ring a bell to you is that this patient could be a patient of underlying sleep apnea. And the same I have seen over the years, where you get a lot of cross referrals now coming in from the counselors, the marriage counselors, and also the neurologists who have now been able to, become very, very understanding of the multidisciplinary approach to OSA. So earlier we used to just joke about the marital discord leading to divorce, but there are major important medical legal issues that have come up now. And this is way back in 2001 also it was being proved evidence-based. So they put two sets of people in a room on simulated steering wheels. So one were people of sleep deprivation and the other were given almost 5-6 pegs of alcohol. And both of them were put on stimulators or simulators to check their driving skills. And they found that the ones on the sleep deprivation sometimes performed almost the same or even worse than the people who were drunk. So that's where the medical legal importance comes in. And a lot of countries across the world now don't even issue driver's license to people who are diagnosed with sleep apnea. And if you look at the epidemiology, and I'm putting these figures in inverted comma about urban Indian males, because I am in a tier 1, tier 2 kind of a city. 75% of my country in India, the entire country of India population, 75% is generally rural. We have 25 to 30% in the urban cities. And that's why we have got figures of the urban India. And that itself is shocking. So you can imagine if you extrapolate this and get, because you're not going to get farmers and people in the rural villages come up and complain to you about snoring. So we don't have, enough data or information about that as yet. But you can imagine how severe the epidemiology will be. And because it's grossly underdiagnosed, because people don't really understand where it's coming from, and what happens is they land up, so you have chronic headaches, you have early morning headaches, you get referred to a neurologist. You have depression, kind of endogenous depression kind of issues or issues related to anything else, you get referred to a cardiologist, to a psychiatrist. Similarly, for hypertension, you get. So what happens is, and this is very important from a primary physician point of view, because when you go to a neurologist, he's going to definitely think in terms of an MRI. A psychiatrist is going to put you on antidepressants. And in all of this, the underlying OSA gets missed. And obviously, nothing may really come out in the imaging investigations. And antidepressant treatment can go on for months together with no improvement in the patient. And by that time, a lot of time has got lost also. Plus, not to mention the fact that you as a primary physician will have to face the patient and their family by saying that, nothing has really happened. We got this test done, we got that test done, we did this, we did that, but still the patient is the same. So this is where the problem comes. So you have to understand who is at risk, and it could be anybody, just you, me, any snorer, non-snorer. But definitely the most people at risk are those who are obese, people who are smokers, drinkers, and we have a kind of a collar size at 16 and a half. When you have a collar size that big in males, females, actually in males it's a little more, females lesser, then you know that the girth at the neck and the adipose tissue there is quite high, and this can lead to a lot of obstruction at that level. So how will they come to you per se in your OPD? Very rarely will the primary physician get somebody who will come to them and say, okay, I've got snoring, what do I do? Or, okay, I think I have sleep apnea, what do I do? And that's why, as a primary physician, you need to maintain a very, very high index of suspicion. And this index of suspicion is related where to the entire quality of life issues. So you get people who come to you with lethargy or not very well, and then the entire cycle starts of getting vitamin B12 test done, vitamin D deficiency to be looked into, hemograms to be done, and ultimately a lot of them probably even come out negative, or even if they come out positive and you've given them and replenished the nutrient deficiency, things are not improving. You will also have to look into people who are facing a complete quality of life issue as a complete whole, not just with headaches or not just with feeling lethargy or body aches or generalized weakness and things like that. So unless and until you're aware of what all can be caused, you cannot maintain that high index of suspicion. So all these patients who come to you, uncontrolled diabetes, uncontrolled hypertension, generalized body aches, depressive behavior, just not up to anything, early morning headaches, not being able to concentrate, having interpersonal relationship issues, and of course, not to mention, like I mentioned already, the hypertension and thyroid or diabetes not coming under control. So you will have to keep your antenna up and maintain a very high index of suspicion to catch such patients, because very few, like I said, will come with the sleeping partner. And when they do approach you for snoring, then you've got to then start asking the partner about questions regarding to, choking episodes or having daytime sleepiness. And, suddenly they are stopped breathing and there's a pause for about 10-15 seconds. And then again, they start breathing. And of course, the noise decibels, because most patients related to the decibel sound of snoring. But you have to understand that the loudness of snoring per se has got nothing to do with the severity of disease. Snoring is just a way of letting the body know that, okay, there is an obstruction somewhere, and that's what needs to be looked into. You will always also suspect it in a certain category or class of patients that come to you. And this is generally more in the obese individuals, those that are, type A personalities, or those who are overstressed, business people, BPO people with, those who are working with the USA timings, those who are catering to the European and American time lag, Australian time lags. They are going to have a very, very big issue with sleep deprivation and sleep related issues. Then you will also have to look eventually, like I said, at depression and other systemic and cardiac causes, and anything and everything that you think is deteriorating their quality of life issue needs to be suspected. In the general examination at your clinic, you will do obviously very, very simple things, but the most important thing that you need to look into is the BMI. You need to calculate the BMI of that patient, which is weight by height square. And that will give you a better idea or a much more better understanding that, okay, with a higher BMI, OSA becomes much more common. Now, looking into the nose is quite easy at the primary physician level. Looking into oral cavity and oropharynx is also quite easy. Is the nasopharynx, hypopharynx, and larynx, or the rest of the airway, where the ENT surgeon actually comes in. So you can also look into the nose, although we as ENT surgeons now use much more sophisticated equipment to look deeper into the nose and try to find out whether there's any kind of an obstruction in the nasal cavity. We also look into the oral cavity. You can also see something like this. And I'm going to show you exactly, how simply in just the OPD itself, you're going to be able to identify the level of snoring. So if you take a look at this video that I'm playing, and you look at the flapping of the uvula, which is so obvious now, you'll see it in a second. The airway below looks pretty okay. There is no obstruction really over there. But if you look at the upper part, when I ask the patient to breathe in and breathe out, here is where you will see the fluttering. See, do you see that? So this lower part of the uvula, when it comes and hits on the base of the tongue at the back posteriorly, that's what gives the sound of snoring to the person. So it's not very difficult, even at a primary care level, to figure out at least one level of obstruction, although it's not as simple as I'm trying to make it out to be. But yes, this really helps. Now the question comes, on your history, you have figured this out. You have done your primary examination on in your OPD itself with a torch and tongue depressor. A lot of y'all already have this. And this is where you are already in your mind decided that this is likely to be a patient of sleep apnea. Because on the history with daytime somnolence, snoring, quality of life issues, all of those things combined, along with the obstruction that you may see, then you need to take a call on what next you have to do. Now, I'll come to that a little more, but you have to understand that every patient of snoring must undergo a sleep study. This is not something that is negotiable. Every patient of snoring must understand and go through a sleep study, because forget what all it tells me, but it also is extremely important to diagnose the condition and know the level of sleep saturation fall that is actually happening. So this is very important for everybody to undergo. You could always undergo a polysomnography like this, which is very, very cumbersome. This is what I had started off doing initially, but if you see the number of leads that are done in getting the patient admitted into the hospital, this is not so easy to convince any patient to get done. And sometimes, many a times, they would not be so keen on doing this. Now, keeping the academic part out of it, I will just tell you that very simply, you can do a level 3 sleep study at home, whereby it's just a simple battery operated device with a pulse oximeter, a thoracoabdominal belt, and a nasal cannula to see the airflow. This also gives us enough information as an ENT surgeon to figure out whether there's an obstruction or not, or whether it's central or not, and then helps us go forward in our treatment modalities or trying to figure out the treatment modalities. You get a whole lot of waves. We have to learn to read them. You get reports like this, which eventually I give a proper detailed sleep study report, which gives the entire details about how bad the patient is, how much snoring has he had, how much desaturation, etc., etc. Now, that's about the sleep study and the physiological aspect of the evaluation. But if you understood now as to how much is how sleep apnea really works. So on one hand, we have the physiological issues with sleep apnea, which is judged by the sleep study. And we also need to find out what is the level of obstruction. So unless you look into the airway, how are you going to find out the level of obstruction and how to go about treating it? And this is where the importance of an ENT surgeon comes in, because it's an ENT surgeon who actually has direct access to the entire upper airway of our body. So with an ENT person having the required equipment and the required in-depth knowledge, just doing the sleep study is not enough. He needs to go in and take a look into the airway and try to figure out whether the collapse is at what level, from all the way down from the nose all the way down to the level of the laryngeal inlet. So you could have a lateral wall collapse of the pharynx, you could have an anteroposterior collapse, you could have a tongue-based fall, an epiglottic fall, or you could have problems at the palatal level. And that's where the ENT surgeon comes in. Now, once you have diagnosed sleep apnea and you have tried to figure out where is the level of obstruction, that's where again the role of a primary physician comes in very, very importantly, because you are their first family physician. You are the person that they will turn to in spite of having gone to the specialist. And that's where you need to talk to them about the test results. You need to talk to them about what all can go wrong if sleep apnea is kept untreated, the cardiac as well as the neurocognitive issues. And always remember, as a primary physician, you need to keep the partner in the discussions at all times. Just the patient alone is not sufficient. The partner has to be there. We always advise them not to do much of driving because this can cause really bad accidents. And if there is a high BMI, then the weight loss issues need to be looked into. Now, let me take you a little through the philosophy of treatment. Since this is not meant for a particular in-depth detail, I'm just going to give you a simple philosophy of treatment of sleep apnea, which is always stage-wise. And as is with every other thing in the world today, So once upon a time, people used to do a lot of cholecystectomies. They've all been replaced by laparoscopic cholecystectomies. A lot of abdominal work is no longer the open incisioning into the abdomen, and everything is done laparoscopically. Similarly, the philosophy for OSA involvement or surgical involvement also is as much possible as non-invasive. And then as things don't work or things become worse or there are deeper obstructions, then you go in from non-invasive to invasive. And the current concepts in treatment are basically multimodality, because it's a multifactorial problem which has got a lot to do with the age, with the weight, with the site of the anatomical obstruction. Hence, you need to factor in a multiple modality treatment concept and not just one size fits all, or not just one surgery to do and get away with it. Similarly, this would depend on what all you have available with you. Okay. And if you look at the treatment options that are available, first thing that I want to emphasize over here is that there is no medical treatment for OSA per se. For OSA per se, the sequelae or the complications of OSA need to be treated. There's no question about that. But there is no treatment for OSA which is medical in any form. Lifestyle issues definitely are a lot. I'm not going to get into that. Everything is related to weight loss. And in today's date, everybody knows a lot about how weight loss is to be achieved and things like that. But the worst part about it is, although we may all want to lose weight, it's easier said than done, because majority of them lose weight very fast with motivation and they gain back again very soon. And that's the problem that I've seen. So I do not advise them crash courses. I do not advise them to join any of these facilities where they offer 8 to 10 kilos of weight loss in no time. I always tell them to take it gradually, slowly, step by step, because there is no medical treatment to it. And so far, the only treatment that has been propagated worldwide was the CPAP devices. But as surgeons now, as ENT surgeons, we have come to that fact, and that's been my biggest endeavor in the past 14 to 15 years, to try and make people understand that CPAP is probably not the only gold standard. There is a lot that we as ENTs can do, because the obstruction is in the upper airway. So if we have a very good and proper assessment by somebody who is very well informed about the subject and knows how to deal with it, then there are ways to treat the obstruction without the necessity of a CPAP. Now, having said that, like I said, it's neither only CPAP, neither only surgery. It's a very tailor-made kind of a decision-making, which is beyond the scope of today's talk, but maybe some other time I will dwell into that in detail. If you look at the CPAP that has been the so-called gold standard today, and you try to use it yourself, you will realize that it's extremely difficult to sleep with something like this on your face. Try sleeping with that. I've tried it. It's not so easy. Yes, for a morbidly obese patient in the ICU or somebody who's not able to, definitely that is the one that we are going to have to use. But many a times doing it on a simpler patient is not very easy for them to take on to the CPAP machine. And that's why we need to get on to the other kind of surgical management, if at all. Now, this is only for the primary physicians, because a lot of patients will ask you these kind of stupid questions because of the marketing that is happening in today's world. They will come and ask you about these breathe easy strips and the silent throat sprays, where you spray something into the mouth and it will become okay. My answer to most of these patients is, once I've explained to them what exactly is sleep apnea and where all the obstructions are, then how is a simple strip opening the nasal ala going to help? And what kind of spray is there that's actually going to open up your airway? So this is all humbug, and this is a lot of marketing gimmicks. In the surgical treatment, we obviously have procedures in the nose, we have procedures for the oral cavity, oropharynx, and we have procedures to pull the tongue forward. Now, this is what we used to do till many years back, and this is how we used to cut out the entire palate and remove everything. I haven't done this surgery now for almost over 8 or 9 years, because there is so much new that has come up and so many other things, that this kind of a morbid surgery nowadays is on its way out, even surgical result wise and even otherwise. We've got laser surgeries also, which become quite easy to do. So under local, you can infiltrate that area. give a proper local injection, as you can see, and then with the laser you can go ahead and remove that floppy uvula that I showed you earlier also. And these are all things which become pretty easy to do on a regular basis, and the patients are quite cooperative, and these give you that kind of removal of the entire obstructive element there. We have now with us radio frequency and coblators. These are very, very safe. They are, controlled procedures. They can be repeated as often as you need to at times. These are the kind of probes that come. And to give you a slight simple example of how radio frequency works, this is a video where the radio frequency energy gets transmitted between two probes and the protein coagulation happens. And that's how simple it is in able to destroy the tissue and then create shrinkage over a period of time. And it is extremely a good technology. I can show you this is done on a cadaver, fresh cadaver. This is the lesions that come up. And when you make 5 or 6 lesions, then automatically the healing is with fibrosis and it shrinks. And then there is hardly much of a protocol to be followed. Of course, we are very safe. We keep the anesthetist, we have monitoring, we do the routine stuff, and then go ahead, and nothing really is needed after radio frequencies. Not much of painkillers, not much of antibiotics, not much of anything that we can use. Right. So nothing really needs to be done over there post RF also. And we tend to get very good results in that. As you can see here at the palate level, the same thing can be achieved in the nose level. So I'm just giving you a little bit of an idea of how the work has become very minimally invasive if required. But needless to say, obviously this goes without saying that if you have patients who are non-motivated, alcoholic and morbid obese, you cannot expect very good results, and your initial work will have to be towards motivating them and getting them off alcohol and trying to reduce their weight before you actually can try to do something on the airway. A little bit of word about pediatric OSA, because everybody thinks that it's only about tonsil adenoids. I have a huge big talk on pediatric OSA, which is also available on YouTube and my website. For anybody who's interested, can please go there and search out that lecture and have a listen to it. But what you need to understand is that most important in a pediatric OSA is the question of recent deterioration in scholastic performance of the child. That is extremely important. So just the snoring and mouth breathing is what the parents will come to you with. But the question that you have to ask them is the school performance. That helps you, because the earlier you look into a pediatric OSA, and we all know this, earlier we used to call this adenoid facies. Now the incidence of adenoid facies has come down very tremendously because of the advent of coblators and surgeries becoming much more safer than what they were. But that's a topic for another different day. I am just going to end with a little bit of philosophical arguments here that I've faced across the country. So everybody, and this is very important from a primary physician point of view also, because your patients will ask you the same question. And unfortunately, in private practice, these are the kind of things that we come across with. We talk always about ourselves being a third world country, a cost-conscious population, where people are not going to spend for investigations or for treatment of something like snoring and things like that. And I'd like to relate a very simple, a small incident which happened to me almost 10-12 years back, because when I got onto the international platform, and I was doing a lot of panel where I was panelist, and I was invited as a panelist and sitting across with people from the other country. And the moderator would ask some questions with regard to this procedure, that procedure. And I would always have to land up giving an answer saying, sir, it looks very good in the West in your country, but in my country, we have a lot of issues with finances and the patients can't afford this and that and blah, blah. And, so there was one senior surgeon from a different country who was moderating the panel discussion, and he heard me out for a few times over 3-4 panel discussions. And then one fine day, he tells me on the stage itself that, Dr. Seema, I think this is all in your mind. I have come to India very often. I have come to Mumbai and I have come to Pune, to your city, to do workshops. And I see more BMWs and Mercedes on the streets of your country than in my country. So it's a lot of nonsense that you say that your country does not have, has got economic considerations. It's probably you as doctors who have not been able to put across the importance of this disorder and the dangers of this disorder. So this is the arguments then I came up with, so is it an overkill to go ahead and do a sleep study or something like that? So there are people, two sets of patients that we get. One would be the ones who would understand everything with regards to the science behind it, and one who would try to weigh the pros and cons with regards to the money behind it. So if you talk to them and explain to them that an undiagnosed, untreated OSA is invariably going to land up with some of the major complications being neurological strokes and, for that matter, cardiac ischemia and things like that, then the pros and cons of the money does not even count. Even if you get a simple hypertension and you're paying 500 rupees a month for your antihypertensives lifelong, then where is just 6,000 when it compares to doing a study and trying to find out and get yourself treated? So this is one of the ways that you can try and make your patients understand, those who do not understand with regards to the scientific part of it. And I would like to give a lot of gratitude to these teachers of mine long time back. Obviously, I was very young back then, but these are the guys from Stanford, which is considered to be the Mecca of OSA. And they are the ones who've made the Stanford protocols. Also, Dr. Horman from Mannheim, Germany. I'm very grateful to them for getting me involved in this field, and the Norway group, as well as the World Association of Sleep Disorders. With a very simple take-home message to all of you all, that snoring has very, very lethal consequences if left untreated. I would use the word an epidemic kind of a disorder, because the figures are very, very huge if you actually go ahead and see them. We don't have the exact figures because a lot of our country stays in non-urban areas. And a lot of deaths during sleep, which get certified on certificate as death due to cardiac arrest or cardiorespiratory failure. And that's the reason why cardiorespiratory deaths are very high on the statistics front. But the underlying cause could obviously be an OSA, but since it is never brought out in the limelight, the statistics don't come out in the way that they are supposed to, or they actually may be. And that's a logistical issue which at the association level I'm trying to deal with. And hopefully someday we'll be able to get out that data to make people understand. So early diagnosis and treatment becomes very important. Don't behave like an ostrich and put your head under the sand and say that, oh, it's okay, I'm snoring, it doesn't mean it's a very big deal. And make sure you get a sleep study done at all times, because this is 100% curable, and non-invasive measures are also very important for us. A primary physician must definitely know how to suspect it. I've already told you how you're going to suspect it. And after you've done a clinical examination, you must really understand at what stage you are going to refer this to a specialist for OSA, because that's when the actual diagnosis and treatment will happen. So ladies and gentlemen, from what we knew just as a light at the end of the tunnel, we've come a very far way, and the picture is quite clear. We know exactly what to diagnose, how to diagnose, where to find the level of obstruction, how to treat that level of obstruction, which particular procedure is slightly better than the other. There is a lot of improvement that has happened in this field over the past 10 to 15 years. And that's what I'm really trying across the country to get people to understand. The future still looks very good, because we have pacemakers for the tongue muscle. We have nerve stimulators which are coming in. We have better and better devices like this. Even CPAP is getting a little better with the tubes like this. And of course, we had the Mangal Mars mission. So, you put a person in a spaceship and send them to zero gravity. Obviously, there's going to be no OSA. So that's also 100% guaranteed treatment for some of the very elite in the years that may come, can happen. So thank you very much for this patient listening. And I would once again thank Dr. Subhash for having me here and the entire team. And I'm going to stop sharing screen and leave the entire platform open for some question answer sessions before I can sign off. Thank you very much.
Sir,
Are there people asking questions?
sir,
Dr.
one
Saurabh, will
question
you take them up?
sir, how to diagnose pediatric OSA?
Okay, so pediatric OSA is basically more of a clinical diagnosis. We really do not expect people to do sleep studies in pediatrics. So when, like I said, the issues will be related to mouth breathing with relation to their hyperactivities. And one of the clinching signs is always a decreased performance at school. So this should really put you on the go, because in a pediatric OSA, most of the times the culprits are the tonsils and the adenoid. And as the first step, we anyway have to tackle them. And we as ENTs have it very easy for us to, really diagnose adenoids. And now earlier it was X-rays. Now we've got even the flexible scopes. So without exposing the children to X-ray radiation, we can just put in a simple scope into the nose and nasopharynx and diagnose the adenoids.
Okay,
I hope that answers that question.
sir, another question is, what is the role of dental oral prosthesis and if they are available in India?
Yeah, so I personally did not, I purposely did not touch on that because it's a very big topic in itself. Yes, they are available in India, no doubt about it, but they have limited use. One has to understand that, whenever you use a mandibular device to try to pull this chin forward or try to pull the tongue forward, you are doing something to the anatomy of that area. And constantly, if you keep doing that for, weeks and months together, the patient develops a lot of TM joint related issues or grinding issues with the teeth or even muscle pain because the whole thing is pulled forward. Having said that, it does have a role, no doubt, but it has to be very, very properly assessed, and only the milder patients where only a little amount of advancement is required possibly can be achieved with these kind of devices. But there again, the person making these devices has to be well trained in this, because malalignments of the entire thing can cause a whole lot of maxillofacial issues in terms of pain and pull of the muscle and joint issues.
Okay, sir.
May I ask a question, Dr. Simha?
Please, sir, please.
Time and again over this lecture, you have mentioned obesity as is one of the main causes for OSAs. You also mentioned the shirt collar, or this neck collar size, and the waist weight. And you have suggested that it would be useless treating a patient who is not motivated to reduce his weight and not motivated enough. Now, suppose I motivate my patient to reduce weight and he reduces his weight to a optimal level. The symptoms of OSAS and snoring will also reduce to a great level. And would that be one of the treatment, or it would be just an adjuvant to a treatment?
Sir, let me try and put it to you in this way. There is a saying in English, which says that hit the iron when it's hot, strike the iron rod when it's really hot. Only then you'll get the results. Now, if I'm finding some kind of an obstruction in the airway, whether it's at the palate, whether it's at the nose, anywhere, let's say, and the patient has a comorbid obesity, right? If I do any procedure at that particular moment, I know it's going to fail.
Correct.
So obesity or weight reduction is a continuum process. We are not giving them a time target, or we are not saying anything. We say continue to reduce your weight, follow up regularly. I have a very clear-cut protocol. I have monthly follow-ups with the patient. You keep reassessing them clinically, because you can't keep on doing sleep studies every now and then and everything, but you keep assessing them clinically and with a scope in the OPD. And the day you feel that, okay, this is the right time for me to attack inside now, that's the time you go ahead and remove the obstruction. Otherwise, removing the obstruction in a, unless, again, let me again be a little bit more clearer. Let's say the obstruction is very clear-cut and very static, like say a deviated septum or maybe a huge adenoid. That obstruction, obviously, we can reduce at that time with a little bit of weight loss, but the dynamic obstructions to touch with a high weight patient. And when we talk about weight, sir, we are basically talking more with relation to neck adiposity. We are more concerned with the neck adiposity and the neck circumference rather than just the abdominal girth. So it's a no-brainer, and it's obviously taken to understand that weight loss is a continuum and it has to continue. It will never stop.
Thank you very much. That was a very satisfactory answer.
Thank you, sir. Thank you.
Dr. Saurabh, any more questions there?
Sir, thank you very much. Thank you, Simak sir.
Thank you,
Now
sir.
I ask Dr. Raj Gupta to please give a word of thanks.
Thanks, Dr. Sinapse, for giving a lecture in such a nice way that everyone can understand what is a sleep apnea. And this can be corrected only by the ENT surgeon. Thanks, Dr. Sinapse.
Sir, just a little bit of correction. I won't say only by the ENT surgeon. We are trying to get a multifactorial, multidisciplinary approach into it. So we have a major role is what is more important for people to understand, because people never really give the importance to
Raj
the
Gupta,
ENT
ENT wale
person
aa gaye.
who is required to clear the airway. So we have a major role to play, no doubt, but not the only person, I would say.
Thank you.
Thank you very much,
Thanks,
Dr.
sir.
Simab.
Thanks, sir.
Thank you, sir. Thank you very much.
Thank you, sir.
all. Thank you,
Dr.
Dr.
Simab,
Raj.
that was a very simplified version of OSS. I'm sure it is not so simple as you made it look. Just like I would rate it like Dr. Satish Jain used to make removal of nasopharyngeal fibroma so simple, but it's not so simple. The ENT fraternity will know that it is not so simple.
Agreed.
But yes, the people who have attended must have enjoyed your lecture, and they must have all got a big orientation as such to what they are dealing with, and high level of suspicion is required to diagnose this condition. Thank you so much for accepting our invitation. Thank you very much.
Thank you, sir. Thank you very much. And I may take your leave, sir, with your permission.
Yes, please do. Go back to your practice now.
Thank you, sir. Thank you very
Lot
much.
of patients, kai patients aapko yaad kar rahe
Thank
honge.
you all for, thank you, Dr. Garg and Dr. Simab.
Thank
And thank you, Saurabh Gupta, for conducting this session. It's been a wonderful lecture and a highly educative one for all. We now move on to the next session. This is again a very interesting session for today. We will be here. We have a speaker who would be talking on the healthcare in the private sector. What are the challenges? What are the responsibilities? And what are the opportunities there? In the light of COVID pandemic that we have been having for the last 18 months or so, a lot of new things have come up. A lot of gaps in the healthcare system have been exposed, and a lot of opportunities are there, and a lot of responsibilities at the same time for all the healthcare faculty to come forward and serve the people of the country. So to conduct this session, I would invite Mr. Abhishek Kapoor, who is the director of Regency Healthcare, the group of hospitals in Kanpur and Lucknow. He would be introducing the topic and the speaker, and he's online with us. So I would ask Mr. Abhishek Kapoor to please take the stage and conduct this session. So over to you, Abhishek.
Thank you, Dr. Bajwa. Hi, Kamal. So I'll just introduce Kamal. Kamal has been a dear friend and acquaintance, and he awareness about a lot of issues pertaining to what we are going through as a nation and as well as healthcare community. I think in the last couple of years during the entire COVID, his role has been instrumental in getting people together and raising the right issues and the right questions. So over to you, Kamal. I think we are addressing a gathering of doctors today, unlike entrepreneurs, which we end up usually doing, but you hosted many doctors. So I'll hand over to you. I think it could be a good thing that how things have actually taken a turn, how things have changed post-COVID, I think awareness has risen about quality healthcare, insurance penetration has risen. How things are, going to impact. So let's hear it all from you. Over to you, Kamal. Kamal, you're on mute actually.
Sorry. Yeah. So thank you so much, Abhishek, for your kind introduction and this opportunity to speak on this, August forum. And it's a unique opportunity and occasion for me, because normally I host doctors and I hear from them. This time it's, kind of going to on a reverse order. And so I will try to, kind of be, of some use in my talk. However, I was hearing the previous panelists, so, I can understand it's more of a scientific conversation. I'm not a doctor and not a healthcare professional as well, but I'm a health enthusiast, and I look at health from both as a layman point of view and also as a consumer of healthcare, and also somebody who appreciate the healthcare system, being around us. And especially, the kind of topic you have, kind of allocated to me, challenges, responsibilities, and opportunities. I would rather change the sequence and we'll talk about responsibilities first. And the responsibilities are so immense that, for a country like India with nearly 1.4 billion people, I think one of the most critical support for life, which is quality health care, is being provided by the private sector. You all know those numbers, 75% of healthcare, at least, is being provided by the private sector. So there is a massive and immense responsibility. And, interestingly, there is no way to, kind of getting away from this responsibility which your sector and your fraternity has. And also, especially in the aftermath of COVID-19, we, as a health promotion organization, were doing a lot of those activities to, kind of make people realize the kind of role our healthcare fraternity had played in saving the humanity and saving the lives of our people during this COVID-19 pandemic. So certainly, I would also like to take this opportunity to express my sincere gratitude to the entire healthcare fraternity and all the doctors and healthcare professionals who have joined on this session today, for their wonderful work, their tireless work, which they saving people, saving lives, and they did not care about their life, and they put more energy and priority to the. My connection might have got little unstable. Is it better? Am I audible?
Yeah, Kamal, you're audible now, but I think it's breaking off a bit, but you're audible.
No, I think it should be better now. It got changed automatically in some other connection. So sorry. Yeah. So as I was expressing my gratitude for the entire healthcare fraternity, all the doctors. Thank you so much for your wonderful work which you have been doing during the COVID-19 time, and you are continue to do that. I would like kind of take up the point of responsibility first, and as I said that private healthcare is playing an immense responsibility, a great role in providing the healthcare of our country in our country, and especially in the scenario when we are seeing the disease burden is increasing every day. NCDs have become one of the major cause of concern, and at the same time we are also seeing the spurt of infectious issues like COVID-19. So we are facing a double whammy and the kind of double burden of diseases and healthcare problem. And in such scenario, private healthcare has one of the most important, critical, and vital role to play. And not only this is important to understand that what I see that earlier we used to think that private healthcare is being chosen by those who can afford and pay for it. But if I see, the trends, and especially, the kind of role in the public funded schemes, whether it is Ayushman Bharat, whether it is this, other government schemes are there, state government schemes there, and the kind of role state, private sector is playing. This also highlights that people in general trust private healthcare providers more than the government healthcare providers. If we just see some of the trends and numbers of government's ambitious Pradhan Mantri Jan Arogya Yojana, which we call as Ayushman Bharat, more than 56% of the hospital registered or impaneled in this are private hospitals. I was, doing a quick search about how many hospitals are providing Ayushman Bharat supported care in Kanpur, and especially in the area of, this urban Kanpur. And I could see that nearly 100 hospitals are impaneled on this scheme. This shows that, no healthcare or effective healthcare can be provided in our country without the strong role of private sector. And that's the responsibility we need to play. And that's the role is carved out for us. And interestingly, it is not that just the registration. Around 63% of the total claim value, total claims under the Ayushman Bharat are being done by the private hospitals. And the total claim value which was reimbursed or is being reimbursed by the government, 75% is going to the private hospital. That highlights a very, very important role which we are playing. And it has been, almost every country which has had a mixed healthcare system, we have the same pattern. And in that light, I think the responsibility is definitely very huge on us. If you see, as I said, and I just tried to, kind of reiterate the point that how the people's trust, because the one of the challenge which we face will later on I'll going to talk about, and as a journalist I experience that the first thing we talk about that people do not trust healthcare, and there is a trust deficit, we normally call it. But if I see, the kind of major treatments being done under the, especially Ayushman Bharat, because that's the, kind of the big buzzword at present, especially, when it comes to the country's dream of achieving universal healthcare. Top 10 treatments like knee replacement, cataract, your hemodialysis or cardiovascular related surgeries were conducted by the private hospitals. That means people prefer to go a private hospital, even a relatively smaller private hospital, than to go a large size of hospitals like Hallett or Ursula, or maybe AIIMS or Safdarjung or LNJP in Delhi. That's the trend, and this is what I think we all, as a whomsoever is contributing to this private healthcare sector, need to appreciate that the people of this country trust you, and that is where is the biggest responsibility, and also opens up great opportunity for us. As far as the industry size is concerned, just to quote some of the numbers which you all are aware also, in 2016-17 itself, our private hospital and healthcare industry became to almost rupees 4 trillion, which is expected to reach almost over 8 trillion rupees in the next year. But apart from this, what is also very important and interesting and appreciable is that private healthcare is not only curing the Indians. We are also have become like our pharmaceutical industry, kind of manufactures drug for the world. Similarly, as private healthcare providers, we are also providing care to the world, and in a manner, the kind of importance we are getting as a medical tourism destination, and the kind of trust and the kind of preference we are getting from the global patients, and not only from your Asian patients or African, but also increasing number of patients from Europe or US are also started preferring India as a medical tourism destination. Also because of our kind of legacy and our strength of providing alternative cares, also healing destination as well. All that shows that we have a very, very strong role to play. And as far as the opportunities are concerned now, as I highlighted that just the Ayushman Bharat case itself gives us enough understanding that if India is moving towards the universal healthcare, this universal healthcare cannot be provided. We are covering 50% of the Indians through Ayushman Bharat, but it cannot be completed, and it cannot be possible to make sure that everyone gets the universal healthcare and all part of the country without the role of private sector. And that's the great opportunity, the public-private partnership, which many times is also being criticized because of the certain challenges or certain malpractices also, which creep in over the period. But at the same time, having understood, even if we understand the challenges or the lackings, healthcare and the public-private model is going to be the most important aspect of providing healthcare. And also, as a lot of burden increasing of NCDs, and the way NCD burden will increase, the demand for secondary and tertiary care is increasing. Interestingly, most of the tertiary care treatments, and especially as in which is evident in other schemes also, is being provided by the private sector, having maximum number of beds or more than what the government can offer, having more the ICUs than what government offers, and having more specialists and experts in private sector than the government sector, makes all that critical, that this increasing NCD is also opening up a great opportunity for private sector to play. And the most important, I think, which is my passion area, and which has been neglected over the period by private sector, is the primary care and the preventive care. I think private sector also need to figure out a way that how they can play an important role in the primary care of the country, because that is where the biggest challenge of our healthcare is originating. We have wonderful hospitals which we can provide tertiary care, right from large cities to smaller cities, or which are no more small cities for that matter. I come from, I think most of the audience today are from Kanpur and the nearby areas. Am I right, Abhishek?
That's correct, Kamal, and you are from Hamirpur, so I called you with all
that
my
is
love.
why I refrain from saying that Kanpur, or terming Kanpur as in any way smaller city, because I belong to Hamirpur or even one of the town of that district. So for me, once Kanpur was a very big city, it was a mega city for me. So from that point of view, what I say that while cities like Kanpur are offering quality tertiary care, Abhishek, your hospital is one of that, and not only Kanpur, Lucknow, Allahabad, and many other places, we are offering that. But what is the biggest challenge is that in our smaller towns and even in our big cities, the primary care is completely non-existent. Even if, sitting in Delhi, if I want to go for a basic healthcare problem, just to see a family physician or a general physician, I have no choice than booking my appointment in some of the Fortis or Max or something like this. I also very strongly feel and have observed this trend that people now, until and unless these are the specialized treatment they want, they do not want to visit a large hospital. So I think that's where, and I am seeing that many of the private big players who have always tried to stay away from primary care or small setup scenarios are now setting up a lot of satellite smaller clinics where people can come for general and routine treatments and checkups. So primary care is going to be an important aspect. I urge the private sector that find out innovative ways. Most of the time, when I talk to hospital owners and entrepreneurs who have set up hospital chains or running hospitals, they say that primary care is not viable or sustainable because you do not get enough treatment volume in that, and the revenue become a problem. So I think there must be some innovative ways.
Find out innovative ways. Most of the time when I talk to hospital owners and
is it
entrepreneurs who have
something, is it my recorded voice or because something coming back to me? I think
there was something, some feed was coming into a microphone.
Okay.
Because this is being live telecast on YouTube also.
All right. Okay. So and also in the preventive care, I think we need to play a very, very strong role. Especially we need to kind of focus a lot of in capacity building, ensuring that we are empowering to ensure kind of ward off as many diseases as possible. Family physician practice is one area I think which need to be restored, because that family physician concept, which I desperately miss from my early days, which I don't find in big cities now, is very important, because I think they become the biggest guardian of your health and can help you, the family, in preventing a lot of diseases. And a lot of specialists also need to kind of empower these family physicians who can help identifying diseases early. I think the previous session was also highlighting this aspect very clearly, that while specialists like ENT are important for sleep related disorders, but at the same time they need to be identified earlier by the other care providers also. On the challenges side, so as we have great opportunity, massive responsibilities, there are challenges also which need to be addressed. And some of the challenges which I feel are need to be tackled are the quality, transparency, and accountability. These are the three areas on which most of the critique about private sector hospitals happen. Quality, as far as the large, big corporate hospitals are concerned, you are sure about the quality, and that's the trust you can see from the trend that people prefer private hospital over the government hospitals. But at the same time, the smaller setups, there is a real concern about the quality of care, because there is not very clear reporting. There are a lot of alleged violations. I would use word alleged because I don't want to be judgmental on that. So quality in the smaller setups need to be regulated, and I think rather than government coming up with regulatory frameworks, I think it should be the industries self regulation which we should look for, and it should be the responsibility of the organizations like Indian Medical Council or the state level medical councils or medical association, India IMA or state chapters of IMA, that how we can bring that quality standards, uniformity, and also the transparency. Many times we end up feeling that the kind of procedures being conducted, the kind of tests being kind of prescribed are not clearly explained to the patients, and which leads to the impression that they are being overdiagnosed, or they are being overprescribed in terms of treatments or other procedures. I would give my specific, very recent example. I faced some chest pain, but it was not anything related to cardiac, maybe a gastric problem. Initially, it was looking like, and I went to a corporate hospital and met my gastroenterologist, and he said, Kamal, gastroenterology, gastro problem normally does not lead to rib kind of pain. So he asked me to meet the chest physician. And before that, I went for a chest x-ray, then I went for a ultrasound. And the moment I went to the chest, expert, without even seeing my ultrasound or even, he just saw very briefly the x-ray, and he suggested the chest CT. So, kind of in a 1 hour time, I had to go multiple tests. So I was little curious that what is the reason, why I am asked to first go for chest, X-ray, then ultrasound. And my biggest worry was that the doctor did not see my ultrasound. Now, if he would have seen it, my, satisfaction would have been higher. I called up the CEO of the hospital, and he came, and then he said that apparently from your X-ray, you need not to have an CT, but since the doctor has said, you should do that. So what happens in this kind of scenarios when the transparency is not there? The one thing I always believe and respect, kind of request all our medical fraternity that do try to speak and hear the patient also, and try to address them in a much more detail. Maybe sometime it can eat into your other OPD time, but I think sometime when they become a possible dissatisfaction case, and where it lead to a lot of other damages than the, so I think it will be worth hearing a patient and explaining also. The transparency need to come, and which you normally feel, and I am telling that for a hospital where from owner to CEO to everyone was my friend, and that hospital I felt, dissatisfied. So what can happen for a normal patient, and what kind of opinion that normal patient will form. And the third important thing is the accountability. Accountability, many cases, especially when these are the public funded, schemes or reimbursed treatments, especially in Ayushman Bharat, a lot of those trends have been seen, denial of treatment, or, kind of overcharging, or sometime not, which also leads to many other, incidences. I think we as a private sector should look into these challenges more than any other challenges. The challenges in private healthcare are, I think, self-generated. We do not have much of outside threat. Government definitely appreciate and understand there are certain vested interest in the governments or in the conventional perception about private sector, where you may feel that they do not kind of appreciate that much. But this realization is fast emerging, that if you want to take care of the health of the people, which is going to be an important aspect, especially in the post-COVID-19 scenario, governments are going to progressively and increasingly dependent on the private sector, and that appreciation will automatically start coming from them. Important is that we need to address our challenges ourselves, and many of these issues also then lead to situation where media trials happen. That is one of the challenge which you can consider is as a external challenge or external threat, where a lot of I think partial understanding or by the media and the over zealotness or over activism from them lead to a lot of demonization of the private healthcare sector. And especially, and as a healthcare communicator also, I deal with those kind of scenarios day in, day out. And especially when a lot of those apparently flimsy claims are made by the patients or their family. In most of these cases of violence against doctors, or the cases where allegation of overcharging or mishandling or medical negligence were leveled against the private sector, the origin of that were not patients. While in many of the other countries, the primary origin of such things were the patients or immediate families. In India, the trend is different. In India, it is most of the time are the relatives or the wider friend circle, and many time even political interest group, who come and say that, oh, aapko itna zyada charge kar liya, itna to hota hi nahi hai. And then they try to create the whole issue out of it. So, and all that is then published as it is, without much of a filtration, but without much of a, I think, balanced reporting by media. So I think all our doctors and all our healthcare players also have a role to engage, increasingly with the media, try to understand them as a very, very important stakeholder in your work, and try to educate them in a manner which is kind of a mutually respectful, because it is critical to deal with media in a way that which is not kind of boomeranging. So it needs to be very diplomatic, but at the same time there is a responsibility to do that. This is one of the challenge which I especially feel, and also changing perception. So we need to overall change the perception of the people, of the society. We have been trying a lot, especially ISW Council took up the cause of healthcare providers and their efforts and their contribution, their sacrifice post during the COVID-19, and we were running the whole we created a mega program called Gratitude Week, and that Gratitude Week was for for entire, so from the Doctors' Days, July 1 till 7th of July, from the last year, we started this new national program called Gratitude Week, which was endorsed by the Ministry of Health and the former minister, Health Minister Dr. Harshvardhan, many politicians, governors, and regular government officials across the country, and from the both private and government sector medical professionals also. This, we believe, is an important effort towards changing the perception of the people, because we want people to start appreciating the role of doctors in your life, and that is very important. If you are not sure about the skills or the intent of your pilot, your any flight is going to be hellish. So, and in healthcare, it is very important to trust, because trust leads to the healing process. You all know that, and that is where we also worked with IMA and tried to convince the government, lobby with the government to create a health memorial and a memorial for doctors, the doctors who sacrifice their life, and also the doctors who sacrifice their lot of comfort. They are working hard, tirelessly. Money alone cannot give enough incentive for doctors to work the way they worked in COVID-19. And we wanted the government to set up a gratitude memorial for doctors, for healthcare workers, which was endorsed by many leaders. IMA, we did with Dr. Jayalal, we did a press conference in Delhi, met the Delhi Chief Minister. And interestingly, the government of Rajasthan and government of Karnataka have announced that they will be setting up a memorial for doctors. These kind of practices are going to change and help a lot in addressing this perception problem. So we need to work on the perception. Apart from that, we have really an important nation building role, and I appreciate all of you for that, and wish you all the luck, and commit to stand by your side in this quest and journey to save the lives of the people.
Thank you so much, Kamal. I think that was very well summarized on all the pertaining issues, to private healthcare. So a couple of things, we can talk about. I think we still have 5 minutes to go. So a couple of things I wanted to talk about. So I think trust issue is a big issue in today's time. I mean, and the trust deficit is actually where all the problem lies, whether it's a doctor or whether it's a private hospital or a group of hospitals. So how do you see this situation evolving? I mean, my personal take is that as and when, I think the trust issue is sort of linked to the payment issue, because the person is making the payment upfront, and that's where the trust deficit is there. And once insurance penetration actually, let's say healthcare was free today in India, would the trust deficit exist?
If the healthcare become free in India?
Yeah, I mean, do you think? So what I'm trying to say is that
trust deficit can always creep in. The reason is that what we deal with is life and death. Even in the Ayushman Bharat case, if you see, there has been a very clear trend that in the packages which are surgical packages, the private hospital tend to shorten the stay of the patients, which many times may be, releasing them a day or 2 days before they should have been, and many times in hurry also. What happens if you see the readmission of the same patients have also been seen increasing. The same patient have been admitted again in 15 days or 20 days or in 30 days time, which is not the case in the government hospital, because there the duration and the stay is longer. And at the same time, when you see the patients stay in medical packages, which are not surgical packages, the stay in private sector is longer. So what I'm saying, that these kind of practices, whether they are good, bad, ugly, that's a different thing. But they apparently have some kind of medical consequences, some kind of quality compromise, or some kind of perceptional problem, because the patient who will be admitted in a private hospital under the Ayushman Bharat will get a free treatment, will feel gratitude, grateful for the government and especially the Prime Minister Modi, because that's where the whole thing is branded that way. But the same patient will face a follow-up problem and will have to get admitted again in 20 days, 15 days time, will start feeling that the doctor did not do their job well, or the hospital did in hurry. What I'm saying that it is not only related to whether you are paying upfront or you are not paying upfront, because for patients who are ready to pay also, many times they feel that they have not been taken care of properly, they have not been consulted properly, they have not been heard properly. So it is not, I believe, is only the case of out-of-pocket expenses. Yes, that plays a very important role, and many of these allegations and many of these issues or start happening, and I think even if we see the site of analyze the site of these disputes occurring, they are mostly at the payment side. where they have to pay.
That's why I was coming from, that the entire trust deficit, at least in private hospitals, is there because when you pay for something that you don't want to pay for, right? I mean, nobody pays for healthcare willingly. Nobody wants to. Even I would not want to, right? And that's when you have to do something. You might be able to go and spend on a holiday, go eat in a restaurant. All that is fine because you're willingly doing, you're getting pleasure in return out of it, right? So thanks for your views on that. Lastly, one big elephant. I mean, you yourself are from the media industry, and you spend considerable amount of years in it. I mean, even in today's time, you deal closely with the media. How do you see the media's role evolving? And you yourself spoke about that the media at times presents a one-sided, biased view. So how do we tackle that? How do we educate the media? I mean, what role can media play?
I believe engaging and educating media is important aspect, because what I have faced in I did a lot of healthcare reporting, and I learned in the process, and that's why I made this disclaimer at the very beginning that I'm not a healthcare professional and not even a kind of a science student as well. What happens many time, journalists and journalism is called as a history written in hurry. Many times journalists are working under pressure. They want to create stories which can be heard, can be read, and they want to do
and have sensation.
Yeah, and have the sensation. They are spicy enough to be kind of get the interest of the people, and human interest stories where you kind of depict this kind of pictures are best to convey. You would not many times the journalists even don't know the difference between heart attack and cardiac arrest. Now, these are the small thing, even, which can lead to a lot of misreporting, or, how these things are handled. For example, one of our very prestigious hospital in Patna, and I normally quote this case. One of the patient was admitted in the ICU, and one of the, for a little longer duration, and one of the attendant, the daughter of the patient, somehow entered, and I'm sure she must be visiting. So the depiction of the story is that she somehow sneaked into the ICU as if ICU was something, a secret chamber, and what she saw and what she filmed in a phone was that 4 doctors and medical paramedics were jumping on the chest of the patient. Now this was the depiction and half an hour story in Aaj Tak. Now actually those were trying to revive the patient and giving the CPR, but the story which was narrated was that ki लाश के ऊपर कूदते रहे doctor. Now, what kind of understanding you may be expecting from the people who made that kind of reporting, even if it was narrated by the attendant and she may be in trauma, she may be aggrieved, she might have this kind of input to the journalist who reported it, but he should have tried to understand that what was the situation, what led to this scene which she saw, and she did not have much of an understanding. We see what has happened by seeing in movies and all that. We have started seeing that that those lines on the lot of life support devices, and we she created that kind of scenes. He said that वहां पर कुछ लाइन नहीं था, मेरे फादर की डेथ हो चुकी थी और वो उसके ऊपर कूद रहे थे. This was a story. We had to tackle this. So what I'm saying that we need to engage them. Somebody has to invest with them. Somebody has to educate them. Maybe medical universities, maybe the Ministry of Health need to come up with some kind of refresher courses for those journalists, so that they can be given at least the important salient aspects of health reporting. You have seen that health reporting had made a lot of damage in the COVID-19 time also, a lot of vaccine hesitancy was generated by that. And that's why, WHO comes up with a lot of those guidelines for the journalists. So I think we need to engage. We can't ignore this group. They are very important stakeholders because they will also help us in making that perception change. They will help us in making our patients, kind of look for early signs of diseases. They will make, people, more health conscious. They will make people spend more on health, more preventive cares. A lot of preventive care will be driven by media's push and the stories and narratives. So they are certainly as critical and stakeholder as maybe the government itself. We need to engage with them in a much more constructive manner.
Thank you. Thank you so much, Kamal. And thank you, Dr. Bajwa and the IMA team for giving Kamal and both of us an opportunity to interact. I think we are done. Unless anybody has any questions, Kamal would be happy to answer, or it can be directed to me. I'm happy to answer. Thank you.
Thank you, Abhishek, and thank you, Mr. Kamal, for such a wonderful coverage of the whole topic. We thought that it was going to be quite a challenging topic to deal with in the first place. So, but you have covered it very well. The challenges are enormous. Even the responsibilities of the medical fraternity, the healthcare systems in general, towards the public is enormous. But as in every crisis, every crisis is an opportunity. So what all we saw in the last 18 months, the healthcare collapsing in most parts of the world, and it just reflected that how much in a false world we were living, that we had good healthcare systems, but they were just a fraction of what was required. The general public suffered a lot, and definitely this gives a lot of opportunities also for the healthcare to come up with more innovative ideas, more opportunities for the youngsters, for other, even job creations can be much more in the healthcare. So definitely a very good presentation and a very educative one. We are very happy to have you, Mr. Kamal, and it was wonderful listening to you. So
thank you so much, sir. I enjoyed talking here. Thank you.
Yeah. And thank you, Abhishek, for organizing this and committing this. So thanks a lot to you also.
Thank you. Thank you, everyone. Thank you. Bye.
Thank you.
So we start our next session in radiology in another 10 minutes time. So I think we start at 4:50, and we have about 10 minutes time in between. You can just have a break, have a cup of tea or something, and then rejoin us in 10 minutes.
अभी आवाज बहुत अच्छी आ रही है आप लोगों की.
नहीं, अभी सर हम लोगों ने वो बाईपास कर दिया और हम लोग खाली सीधा लैपटॉप से ही जा रहे हैं.
हाँ, तो अब ये बहुत सही आ रहा
है ना, इसी को कंटिन्यू करते हैं.
हाँ, वो सिस्टम कुछ गड़बड़ था.
ठीक है सर, I think you can have a cup of tea and then we come back, please. We have an interesting session in radiology, which is about the radio diagnostic implications in COVID-19, and a lot of good things we are going to hear from Professor Nandani, who is from HOD of radiology from Jamnagar Medical College in Gujarat. So it will be very interesting and very informative too.